Morning all. So yeah, I'm Budd Mendis, one of the diabetes consultants here at Queen's, and Steve contacted me about just because even from our point of view, diabetes point of view, it's been really difficult to keep up with the advances in the technology that have happened in type 1 clinics over the last 4 or 5 years, and it seems to be increasingly getting more and more sort of confusing because there's so many new devices coming off which do different things and they're increasingly complex. So I just thought I'd give you an overview on the different sort of pumps, some of them how they work, who we select for pumps, and some of the other technologies such as the sensors, Libra, and the newer sensors that are available that we're using, and just a bit of an outline in collaboration with the guidelines. Right. So in terms of insulin pump therapy, our usual care, as you know, is multiple daily injections, MDI, which we use for a basal bolus regime, and ideally our type 1 patients should be carbohydrate counting on the basal bolus regime, and we're a very large Daphne centre. So Daphne is our structured education course for patients with type 1, stands for dose adjustment for normal eating, and we are, I think, one of the largest Daphne centres around the country, and Daphne's run in about 90 centres around the UK now, so it's the most widely used type 1 structured education course. So the reason I'm saying this is because our patients that we do put on pumps are Daphne trained patients as well. So nationally, uptake of insulin pumps is about 15% of patients with type 1. But NUH would probably, despite trying to be very selective, actually we're probably about 25% of our patients on type 1s, and in our paediatric population is about 60% and growing actually, and all these youngsters are now coming through our transition clinics into the adult service. And a bit of background in terms of who gets pumped. So nice recommendations is that insulin pump therapy is for people who are unable to achieve who achieve target HbA1c, so below 69, but experience disabling hypoglycemia, or whose HbA1cs have remained high despite sort of high level of care, which is sort of Daphne plus intensive therapy. Having said that, I think the guidelines are a bit outdated in terms of the fact that you're almost waiting for people to fail before you can offer them a pump. So we have a monthly pump panel where we sit, myself, Tasso Gaziz, and a paediatric diabetes team, where we discuss all the new referrals, and we are using other criteria such as patients planning pregnancy, fear of hypos, gastroparesis, or people with dawn rise. So we're not just sticking rigidly to that, because otherwise it's quite restrictive. You probably know this already, but just a brief summary of how insulin pumps work. So this is sort of classic insulin pump. It's got a reservoir. Depending on the pump, it can hold up to 200 or 300 units of quick-acting insulin, delivered via the sort of plastic tubing through these infusion sets or cannulas. There are different types of cannulas we use. Most of them are Teflon, but we've got some patients with allergies and things who use steel or metal cannulas as well. And the difference in the pump from the MDI is it contains purely quick-acting insulin, so usually Novorapid or Humalog, which is in the pump, and it is trickling in hourly at a basal rate. So it's quite different to the MDIs in the sense there's only one type of insulin traveling in, but the quick-acting insulin works then as a basal and a bolus together, and then the pump's pre-programmed with various settings. So the pump would be pre-programmed with basal rates, which could be hourly, also programmed with the insulin carbohydrate ratios and correction factors. So that way, when a person with diabetes inputs their blood glucose level into the pump for a bolus, the pump will calculate that it needs, X number of units for the carbs, plus X number of units for a correction dose as well to bring them down to target. And depending on the pump, it can deliver up to 0.1 of a unit as well as a bolus, and the basal rates. So we're offering much smaller doses and more flexibility. And these are some of the pumps we've got in use. So this one on the left of the screen, this is a Tandem T Slim, which is a touchscreen pump. These are all tube pumps. This is the Medtronic, which you might have seen, the most commonly used one. This is a Dana pump, and this is a new one called an Ipsomed. This one, which you see more and more of, is what we call a patch pump. So it's a tubeless pump called an Omnipod, and the Omnipod, everything is in this pump, in the pump device itself, the cannula. So you fill up actually the little pod with insulin, then you attach it, and it's got an inserter which then sticks for 3 days, and it's everything is controlled by the handset, the separate handset. So in 3 days time, you actually remove the pump, put a new one on and disconnect it, just connect that to the handset, and then away it goes. The others are all tubed pumps, so they all got the reservoir of insulin, which then via the tube attaches to the cannula. So the Omnipod has been a very popular one because of the ability to have no tubes. But some of the others are now becoming different in the sense you don't have to actually, say the Medtronic one in the middle there, they're developing an app so you can control it all via the app rather than having to fish the pump out wherever patients store it. And the potential benefits of pump therapy is obviously improved glycemic control, reduce hypoglycemia, and improve quality of life. And there is evidence behind it. I won't go into too much detail, but particularly regarding severe hypoglycemia. The main advantage of insulin pump therapy, why we would choose that over basal insulin, is that these are sort of basal insulin needs throughout the day in various age groups. You can see that they do vary, as you know, particularly early hours of the morning, where we see some patients experience what we call a dawn rise with their blood glucose levels. So you do see insulin requirements go up in that group. But you see basal insulin needs vary throughout the day. Whereas with our current system of injections of MDI, if you're on a long-acting insulin analog such as Lantus or Levemir or Tresiba, it gives you a flat level of insulin throughout that 24-hour period or 12-hour period, depending on how often it's used. Whereas with a pump, as you can see, you've got flexible basal insulin, so it can match the diurnal basal needs. So very often you may see a sort of increase in insulin levels overnight, and then a drop during the daytime, maybe increase again. So it gives, and what we recommend our patients to do something called basal rate testing. So ideally, a couple of times a year, they should be doing fasting periods where they're fasting for a morning or an afternoon or an evening, and do a couple of these days to identify that their basal rates are set. And with the fasting period, so let's say they're doing a basal rate test for an evening, they'll fast from 5 o'clock until bedtime, and the idea is that their capillary glucose levels should be within 2 millimoles from start to finish. So clearly, if it's dropped by 2 millimoles by the end of the fasting period, their basal rates are too heavy. If it's gone up by more than 2 millimoles, then their fasting rates their basal rates are insufficient. So the patients should be doing that. Usually, we try and get them to do it a couple of times a year, maybe winter and summer, because there is variability then. And pumps have reduced variation, a bit more physiological insulin delivery, and a bit more predictability with glucose levels. That's the idea. And as I said, we do hopefully try and pre-select our patients so they are the more motivated ones that have done DAPNE and carb counting, and ones that are able to manage the pump. But having said that, we particularly, as I said, with more kids coming through, 60% of pediatric population through, it's not always the case. And again, a little bit more variability, because even the long-acting insulins, as good as they are that we've got available, the analog ones, there is variability in them as well. And in terms of the pump, as I said, it's not just delivering basal insulin, but a lot of our patients think it's a sort of plug and play. That there's this misconception from some of our patients with diabetes: I want a pump, to plug it in and it's going to do the job. And as I said, we do try and pre-select them. In the pump, you set blood glucose targets that the pump will try and correct to. So often maybe 5.5 to 6.5 or 7 is what they'll try and correct to. The other thing that the pump does is it calculates insulin on board. So we have some patients that particularly will maybe give boluses to try and correct, but the pump is going to calculate the amount of insulin on board from the previous bolus and factor that into the next bolus, because on the pump, when you set it up, you can set it up to say that it's going to have active insulin time of 4 hours. So it's going to keep, it's going to track how much insulin is on board when you're calculating further boluses. Some of our patients try and get around this by because they, if they want to tighter control, by actually not using what they call the bolus calculator or the bolus wizard, and maybe put in manual boluses. We've even got people that put in fake carbs into their pump to try and maybe give a bolus. And like I said, the other functions are variable basal rate patterns. We can also do temporary basal rates. So, for example, in times of stress or illness, patients can increase their basal rates. So starting rate is 100%. So particularly with their sick day rules, they can increase their basal rates up to 200, or decrease it, suspend their basal rate. So it gives a lot more flexibility in giving more insulin, particularly with sick days or any illnesses. and they can suspend the bolus, and even for larger boluses, they can do something called an extended bolus. So certain meals may need a longer bolus, or may need bolus over 2 or 3 boluses at a time, so that you can give like an extended bolus or a combination bolus. So it does provide much more flexibility. And the expectations from our patients with diabetes is they have regular contact with our pump educators. When they come to clinic, we download their pumps. So we can see, it's in the old days, obviously, as you know, we'd have people coming in with their diaries and handwritten of their blood glucose levels, and often it was all be in the same pen, all between 4 and 7, yet their HbA1cs don't tally. So now actually when people come to the clinic, we download their pump, and actually the pump doesn't lie. It tells you how many boluses they've given, how much they're using the bolus wizard, if they're putting the readings into their pumps and stuff like that, so we can interrogate the pumps. And I think it's been quite useful for some of our patients who've come in with DKAs and things like that. We've had a couple on ITU as well, and then we can then download the pump and interrogate it and see what's exactly been happening. And the pump warranty lasts for 4 years, so every 4 years the patient will go back to pump panel to decide whether they get a renewal. And as I said, it's the same. I've already said this, but you can vary the basal rate hour by hour. We tend to not do an hourly thing. It tends to be in blocks: overnight, morning, afternoon, evening. And it also increased flexibility around dawn rise, meals, exercise, menstrual cycle, sort of physiological and psychological stress. But in terms of troubleshooting with the pumps, as I said, they are running purely on quick-acting insulin over a 24-hour period, so they do not take any long-acting insulin. So even with some of our young adults who are really non-compliant, as long as they're taking their background insulin a day, you know, the Tresiba or the Lantus, they generally keep themselves safe. The thing with the pump is there is no long-acting insulin on board, so any interruption to that insulin delivery, most common source is cannula blockage. Cannulas should be changed every 3 days. I'll show you some cannulas at the end. Cannulas should be changed every 3 days, 2 to 3 days. So if they're not changing that cannula, if it's blocked, dislodged, pulled out, ketosis can develop within 1 to 2 hours. Again, for medical patients, if they're not incapacitated and they are in for something else, then they're potentially safe for using the pump in the hospital. If not, we need to keep the pump safe, give it to a family member, lock it away. And then the other thing that patients should do is, if there is any issue where their blood sugar is rising and ketones developing, we ask them to do what we call a full set change, put a new cannula in, refill, new insulin, and potentially use a pen as an interim until their blood sugars come down. Flash glucose monitoring, you've probably all seen. You've all seen the Freestyle Libre 2 device, and it's been around for about 5-6 years now. Yeah, our former Prime Minister was one of the early uptakers of them. And initially, when Freestyle Libre came out, it was self-funded, cost about £50 per sensor. So each sensor lasts for 2 weeks. So patients were paying about £100 a month for a sensor. But then in the last 4 or 5 years or so, they've now been available on NHS prescription for certain cohort of patients. And our guidelines for Freestyle Libre 2 Freestyle Libre is the patients with type 1 diabetes who are on multiple daily injections and who have a problem to fix, such as hypos. But then we've managed to expand it to pretty much all of our type 1 population by saying if they're suffering from some psychosocial problem that could be helped by the Libre, then they're eligible for it. And then the guidelines have since widened, so they're eligible for patients with type 2 who are pregnant, planning a pregnancy, or on dialysis. And then current NICE update from earlier this year suggests that patients with type 2 diabetes on multiple daily injections should also be eligible, fit the same criteria as patients with type 1. So that's currently in negotiation with sort of commissioners as to how we're going to implement that. And there are 2 main things. So you've seen the Freestyle Libre, which I'm sure a lot of you have seen, which is the pod on the back of the arm. Patients then use their phone, flash their arm, and they get a reading. So that is what we call ISCGM, so intermittently scanned continuous glucose monitoring. And the alternative is RT-CGM, or real-time CGM. And the differences are, with the intermittently scanned, or the Libre, patients physically need to scan to get the reading. With the real-time is continuously monitoring and then sending live updates to their device, to their reader or their mobile phone. Freestyle Libre also has an alarm function, which when it's low or high will trigger the alarm, and it will tell the user to scan, but it won't tell them the reading, whereas real-time CGM would actually tell patients, this is your blood glucose right now. And it's changed the way we work in our diabetes clinic now, because HbA1c is what we've historically used and what you'd still use for your, for surgical guidelines and so forth. But now we spend a lot more time in our clinics looking at time in range and time below range. So time in range is because the devices are continuously recording, gives us downloads, and the time in range is how often their blood sugars are between 4 and 10. And we're aiming for, so patients with diabetes, we're aiming for a target of 70% in that range, 70% of the time. And time below range is how often their blood sugars are below 4, and we're aiming for 4% or lower in our patients with type 1 diabetes. So it's a really useful marker of what goes on in their day-to-day life, because as you know, an HbA1c could be falsely low because they're hypo all the time, or it could be 55, but it means they're really high half the time, really low half the time. And just I mean, I'll talk about Freestyle Libre, say this applies to real-time CGM as well, but there's a tiny filament, and it's measuring the glucose in the interstitial fluid. And it's sort of been a reliable indicator of glucose levels in blood. But there's a couple of caveats. So there is particularly with Libre, there's a time difference about 5 to 10 minutes. Between what we're measuring on the back of the arm versus a capillary. So the caveats to the patients are that with the Libre, when you do scan, it gives you an arrow to tell you which way. And I think the most useful thing is a trend arrow. If you're heading up rapidly, heading up slowly, level, and then so forth, downwards as well. So if the blood glucose is 5 and the arrow is pointing right down, then they know that they will be dropping. But just to bear in mind, there is about a 5 to 10 minute lag between the sensor reading and the actual capillary glucose. With the real-time CGM, such as the Dexcom, that lag is much smaller, and you don't even need to calibrate them. But what would particularly when correcting a hypo, if patients are low, they correct their hypo. We would then say, once you've corrected it, do a finger prick, because they still think they're hypo 5 to 10 minutes later. It's just because the Libre hasn't caught up yet. And also the margin of error is greater at the extremes, when it's low or when it's high. It's very easy to fit. It comes with a little applicator, hold it on the arm, squeeze it, and it fits it. Waterproof, it stays on to 2 weeks. It's DVLA recognized, it gives you predictive arrows, and it joins the dots. And in our clinics, the Libre device is uploads to the cloud via smartphone. So in the clinics, even for remote consultations, this is what we see. We can see this is their sort of average glucose profile, and we can see day by day. And you can see in this person, what they tend to do is they go a bit high, then they correct, such as on Saturday 15th, they've been high, they've given a correction dose, it's dropped down, then they've overcorrected their low, gone high again, and they've overcorrected their high again. So this is this roller coaster pattern, and it's really useful. And then I said, this is the thing where we get the time in range, and this person is spending far too much time low, and it tells you when they're low. Real-time CGM, as I said, are slightly different to our Freestyle Libre devices. So these are the devices you might have heard of, such as the Dexcom G6 and G7, Medtronic Guardian sensors, and coming soon, we've got the Dexcom 1 and the Libre 3. So I'll just update on the Dexcom 1 is a real-time CGM, which is much cheaper, and it's going to be similar price to a Freestyle Libre device, but it'll be a real-time CGM. So I've just managed to get that through formulary, and it's waiting for a business case. So I think you'll start to see a lot more people on Dexcom 1 compared to a Libre 2, because I think given the choice, most patients would prefer a real-time CGM rather than a flash one. So that's going to be, over the next 12 months, really increasing in numbers. And these are more accurate. They don't require calibration. There's less lag, and they can be used on mobile phone apps. And the other important thing is they've got pump connectivity. Dexcom has been funded for all type 1s in pregnancy as well, due to the concept study from a couple of years ago. So our patients will get 12 months of Dexcom funding as well in pregnancy, regardless of whether they're on a pump. And these are some of the devices. So this is the Dexcom device, and that's the applicator for the device. It's got the sort of transmitter in the base, and then the sensor here, and then what happens is that you then, the sensor here and then the transmitter. The transmitter lasts for 3 months, and the sensor you change every 10 days, and the same for the Dexcom, for the Medtronic one. And this is a Libra 2, and this is the new one, which is the Libra 3, so it's a much smaller device. And when I talked about pump connectivity, and this is what you may have seen off with more and more of our patients, so it started off about 5-6 years ago with the Medtronic 640G, which is this pump here. And it had what we call a predictive low glucose suspend. So it triggers a smart guard, the sensor at certain with this 30-minute window, and it's got a predictive low glucose suspend. So then the pump will suspend insulin delivery at that stage to avert hypoglycemia, and as the glucose starts to rise again, the pump will then kick in. And that's what we had about 5 years ago with the low glucose suspend. And then we sort of see these really complex downloads in clinic. But now the latest thing is a hybrid closed loop. So this is not just a low glucose suspend, but a high glucose involvement as well. So you see more and more of our patients in the adult team, but actually lots of pediatric patients now on this hybrid closed loop coming through to adult clinics. You've got a Medtronic 780G with its own sensor. Then there's other pumps like the Tandem and the Dana, which use a Dexcom device. And this is life-changing tech, because patients will know that whatever they're doing, that the insulin it's always delivering small amounts of insulin. It's cutting off delivering more insulin to maintain them in that target level. And now the Cambridge team have developed something called the CAM APS app, which is the Cambridge Artificial Pancreas System app, which is almost like a fully closed loop system. However, with this loop, patients still have to carb count and still have to bolus. The hybrid closed loops are not so sophisticated that they can manage food boluses yet, so you still need to bolus, but the Medtronic system even learns and adapts, and it works incredibly well. And looking at this download, you can see that these sort of pinkish colored towers are the basal insulin delivery. And as you saw with the first one, it'd be like a basal insulin for 4 hours and slightly increased for the next few hours. But this one is giving sort of micro boluses all the time, then it cuts out micro boluses all the time, and this does this all the time. So it's working like the artificial pancreas system. And the feedback from patients in clinic is truly phenomenal, because we've been part of the national hybrid closed loop trial, and we've had patients whose HbA1cs have gone down from 80s to 50s within sort of 6 months. People's time in range or time in target has gone from 35 to 70% within sort of 3 months as well. And everyone says it's life-changing. So our pump panels are using more and more of these now. And there, as I said, there's a fully closed loop system. So there's a Cambridge artificial pancreas system, which is a licensed system. And then some of our patients you may have seen do DIY artificial pancreas system or DIY APS. The most common one is Android APS. And this is patients who've got an old pump and a Libra, and then they've hacked it. And then there's an algorithm which is available on the internet. This is set up by people with diabetes, where the data gets stored, and they're developing these closed loop systems. And it sounds rather scary, but actually you need a fair bit of kit for this, but actually the results so far have been outstanding. I won't talk too much about the different systems, but Android APS is the most common one, and some of them even actually learn, adjust, and some of them actually look after bolus food as well. And we think it is really, so far, there's been very minimal incidents, seems to be very safe. The way they've set up the algorithm is you have to work through certain steps to get to where you want to go. So you cannot go to the next module without completing the previous one. So it seems very safe, and we've had sort of demonstrated even locally big improvement in HbA1c and time in range. And then in terms of how this fits into, I mean, you're well aware of the sort of pre-op guidelines, perioperative guidelines. I'm not going to spend too much time on that. I was just going to show you some of the tech, but the Diabetes Technology Network has also got it guidelines. So the DTN is a separate branch of the Association of British Clinical Diabetologists that bring out best practice guidelines for people on using the technology. And we've talked about the benefits and the risks, particularly of pump failure, no basal insulin, so ketogenesis being avoided, and if a patient is not able to manage them. And manufacturers say that we shouldn't be using the pumps near diathermy or X-ray machines. So if you are using, diathermy, you potentially position it away from there, disconnect it for CT scans and things. You can leave the Teflon cannula in, but disconnect the pump. And again, patients should be using the Teflon cannula, not steel cannulas. Ideally, those with short fasting periods should be using the CSII pumps rather than sort of long longer procedures, and the ability to replace the pump with a variable rate should always be there. So yeah, so on admission is sort of checking the capillary glucose between 6 to 10, making sure the cannula's in. You know, if it's obviously if it's a local anaesthetic, as the patient with diabetes able to use that pump throughout, then if that's the case, then it should be safe. If it's a less than 2-hour window for the operation, then you can potentially check the capillary glucose every 30 to 60 minutes, not with the sensor, keeping away from the diathermy. And if the blood glucose rises above 12, then they need to swap to variable rate. And this is from the Diabetes Technology Network guidelines. So what they recommend is if it's an elective procedure without sedation, blood glucose is in the acceptable range, then you can leave the CSI, leave the pump running, but switch to variable rate if there's any problems running at their usual basal rates. Ideally, if they've had basal rate testing, their basal rates should hold them. Obviously, then there are other problems, aren't there? Stress involved and things like that, which may be having an impact. But anything more than that, or anything with more than 2 hours, or patients more likely to miss more than one meal, or surgery requiring diathermy, then we say remove the pump and use variable rate infusion. So this is from the Diabetes Technology guidelines, and then this is from Plymouth, who've got a very similar guidelines, have adapted it. As I said, the Joint British Diabetes guidelines are potentially adapting next year. The hybrid closed loop data is about to be published, and I think that will lead to a nice update. And I know that our local NUH guidelines, Dr. Medina, who runs the Perioperative Diabetes clinics, is currently updating them. And I think that's pretty much what from DBS guidelines is what's going to go in there, is what I've copied and pasted there. And locally, I think our guidelines need updating for inpatient pumps, because at the minute on the medical wards, we don't have a separate pump prescription chart. So I think that needs changing. And as I said, we've got a rapid increase in hybrid closed loop numbers.